Hello orthopods, welcome back. Today we'll be talking about supracondylar fracture. So the supracondylar fracture, which is the most common fracture seen in the children, and it is most common around 7 years of age, and is also more common in males than that of the females. Why do you think it is more common around 7 years of age? Why is there a specificity? Because during this time there will be highest ligamentous laxity, and also the mode of injury is also more common at this type of age, that is hyperextended elbow. Okay, and in the hyperextended elbow, what is the type of fracture that it causes? It is a bending tension type of fracture, and the flexion type of fracture is very rare, but it can also occur. Why is it that it occurs only at the supracondylar region? Because the supracondylar region has a weak metaphyseal region, and that is why that is the most common region that the fracture occurs. So next, coming to the classification, there are two types. One is flexion type, the other one is extension type. Extension type is more common. The flexion type is also present, but which is a very rare type. Usually it will be associated with high energy traumas and also associated with ulnar nerve injuries. The extension type is further classified based on the displacement and alignment by the Gartland. So the Gartland classification has four types in it. The first one is there is no displacement and there is an acceptable alignment. I'll come and let you know what is an acceptable alignment. The next thing is incomplete displacement and posterior contact will be maintained. The third type is complete displacement. That is, there is no contact between the fractured parts. Okay, and there is also type 4, where there is complete loss of anterior and posterior periosteal hinges also. So it is a very high injury and very unstable in flexion and also in extension. So why do we need to do this classification? Because the classification tells us about the type and structure of the fracture. It tells us the way to reduce the fracture and also treat the fracture. Okay, so it helps us to plan the treatment and also lets us know regarding the prognosis. Okay, so that is what I've given here. So how do we diagnose this? The diagnosis will be mainly based on the clinical examination and radiological findings. So coming to the clinical examination, what do we look for? The first thing we look for is the position of the limb and how the limb actually looks. Okay, whether there are any observable deformities, or if the carrying angle is normal or whether it is displaced, if there is any sign such as Pucker's sign, S-shaped deformity, and if there are any injuries, we have to check for neurological disorders and neurological injuries and also the vascular injuries. So check for vascularity, nerve injury, Pucker's sign, S-shaped deformities, carrying angle, etc. So the most common nerve injuries that occur in this supracondylar fractures are neuropraxic type. Okay, mainly because of the compression. So the most common nerve involved is anterior interosseous nerve. So these are the signs that we can make out in an adult. What do you see in a children? Okay, because it is commonly seen in 7 years of age and below that. So the children, we have 3 A's: agitation, anxiety, and increased requirement of analgesia. Okay, these 3 things indicate the hand is going for compartment syndrome and which require immediate attention. Okay, so coming to the type 1, Gartland's type 1 type of fracture. So type 1 is an undisplaced type of fracture which has an acceptable alignment. And how do you say whether it has an acceptable alignment or not? So first thing is, we take a radiograph of the elbows in both AP and lateral views, and we draw a line, something called as anterior humeral line. Okay, the anterior humeral line will pass through the capitulum. Okay, that is when we say that it is an acceptable alignment. This is seen in the lateral X-ray. Okay, next, the one more thing what we see in the lateral X-ray is fat pad sign. Okay, if the fat pad sign is present posteriorly, it indicates that there is a fracture. Okay, so one more thing is the angle between the humerus and capitulum. Normally it is approximately 40 degrees. If it is less than 20 degrees, it needs correction. Okay, next, how do we treat this? So the treatment involves mainly the cast immobilization for 3 weeks. Why are we setting it for only 3 weeks? To prevent the stiffness. Okay, so the problems with the type 1 mainly are because of the weak medial column. Later on we can face something called as varus malalignment. Okay, the medial column completely collapses and the lateral column grows as usual. So there can be a varus malalignment. Okay, how do we note whether there is a varus malalignment or if the fracture is going to varus malalignment? Okay, we can see something called as crescent sign, that is overlap of capitulum over the olecranon. Okay, that is called as crescent sign. So how do we say whether there is, if this should be corrected or not? Okay, whether this should be corrected or not will be told by the carrying angle. If the carrying angle is maintained, then no need to correct it. If the carrying angle is getting disrupted, then you have to give importance to this crescent sign. Okay, that means what I meant to say was carrying angle is disturbed and you also see crescent sign, then it is a definitive thing that you have to look for the varus malalignment and fix it. Okay, so what are the corrective osteotomies that we normally do for varus malalignment? Okay, lateral closed wedge, medial open wedge, and oblique osteotomy with derotation. Okay, so when we are going for lateral closed wedge, it is easy and most stable and most common type of alignment correction. Second one is medial open. When you are opening, then we use commonly bone graft. Okay, oblique osteotomy with derotation. This is one more type.